Hi, I'm Jack West, medical oncologist at Swedish Cancer Institute in Seattle, Washington. I want to start a new series called Case in Point that describes some of the key issues we face in the cancer clinic and describes the decision-making process for these issues through an illustrative case. One I wanted to start with is a 62-year-old woman who was referred to me from one of our thoracic surgeons several weeks after she underwent surgery for an early-stage lung cancer. Now, this particular one was node negative and measured about 3.5 centimeters, which is in the range where we would not necessarily recommend any post-operative chemotherapy. Nevertheless, her particular cancer had some features that left the surgeon and myself, as well as all of us who discussed her case at one of our recent thoracic oncology tumor boards, somewhat concerned about her risk for recurrence being higher than for some other people. Specifically, her cancer is poorly differentiated, which means that it looked particularly chaotic under the microscope, and poorly differentiated cancers are associated with a higher risk of the cancer returning in an overall more aggressive behavior than better differentiated cancers. In addition, her cancer had what's called angiolymphatic invasion. Specifically, it invaded some of the lymphatic vessels in and around the tumor, and that is associated with somewhat of a higher risk of the cancer spreading after the surgery. And then it also spread into the pleural lining, which is also associated with a higher risk compared with other tumors of the same stage that do not invade the pleural lining around the lung. And so I had a careful discussion with this particular patient about whether I would recommend chemotherapy or not. In fact, we discussed the risks and benefits, that it isn't a proven benefit for patients with a node-negative cancer, certainly that's less than about 4 centimeters, but in fact, the real key factor in a recommendation of whether to pursue post-operative chemotherapy to reduce that risk of recurrence or not is really based on how much of a risk we think a particular patient has, and that isn't necessarily entirely boiled down to just the size of the tumor, although that is a critical variable. So we factored in her characteristics of the cancer that suggested it may be more aggressive than another cancer of the same size. We talked about her overall health, which is very good, and her relatively young age in her early 60s. And putting all of this together with her own preferences, she elected to pursue post-operative chemotherapy. The specific chemotherapy that I recommended for her poorly differentiated adenocarcinoma was called cisplatin and pemetrexed, or Alimta. And there's really no clear best choice, though the cisplatin-based doublet combinations are clearly the ones that have the most evidence to support them, and that's what most of the experts would recommend. That is certainly my preference as well. What drug to pair with the cisplatin is certainly a matter of individual physician choice. There's no clearly optimal doublet combination, but for an adenocarcinoma, my preference has been to use Alimta or pemetrexed because this agent is not only often very well tolerated, but may have particular utility against an adenocarcinoma. So that's still in the process, but I wanted to highlight some of how we make the decision or the recommendation about whether to pursue post-operative chemotherapy or not. Certainly stage is a big factor. The tumor size is another important issue, but patient preference, health, and some of these other less clearly tangible and secondary issues also can factor into the equation and maybe lead us to recommend chemotherapy for people who don't necessarily have a clear need for it in the by-the-book textbook answer. In truth, in the clinic, the issues can be murkier. I hope that's helpful. Take care.